Can I ask all microphones are turned off unless you're speaking or asking a question? It will make it easier to hear. And if you need to ask a question, please raise your hand in the normal way. That'd be great. We've had apologies from Simon Adams, Julia Neal. I think we're probably best to wait and see who else turns up before we attach any other apologies to this meeting. Do we have any uh, declarations of interest? I see lots of shakes of heads, so we'll move on. Minutes of the last public board meeting on the 26th of March, 26. I think I noticed one error. It says at the top 26th of March 25, but that needs to be updated to 26. There's a typo there. Can we just go through those minutes from last time just for accuracy? So page one, is everybody happy with those? Page two, page three, page four, page five. I'm getting lots of nods, so we'll assume those are good, an accurate reflection of the meeting on the 26th of March, 2026. And we'll take those as a full document. We have matters arising. Vicky, you start off. Your microphone's muted, Vicky.
Hello. I'm just looking for the document to share, and I can't find which enclosure it is. Hold on a moment. Paul, do you know which one it was?
It's number 11.
The number 11. Thank you, Debbie.
Yeah.
I'll just open that. Okay. And I'll share my screen. There we go. Can you see that? I move that across there.
Yeah,
You
fine.
can see that?
Yeah.
Yeah.
Great, thank you. Okay, so the business plan, we had quite a lengthy business plan, which we have condensed and reworked into this document to take us through the last 12 months of Healthwatch Worcestershire. So it contains 4 strategic objectives. 3 are listed at the top here, and then the 4th one I'll get to later on, which looks at the closure of Healthwatch Worcestershire. So the strategic objectives, we've got there's nothing new here really, but working with patients, carers and communities to understand experiences, provide clear insight about people's experiences, influence improvements, all those things that are our core work. So the strategic objectives haven't really changed. And then in terms of laying out our work and what we're going to do, we've categorised these into work streams. So I'll go through them. We've got core services, monitoring and listening, improvement and learning, and focused reviews. So the core services are really all the day-to-day activities, a lot of those that the engagement officers do. So the signposting, gathering feedback from patients, carers and the public, reaching out to communities, and providing information advice on health and social care services. So those are all ongoing work that we do day to day. So the monitoring and listening is, so we're looking at these areas, so primary care, hospital services, children and young people services, community hospitals, local service, role of voluntary organisations in supporting healthcare. So those are the areas. So what happens is that the directors will be going to meetings and informing decision makers and people who shape the systems through information that we gather in our reports, etc. So those are the areas that we are covering with monitoring and listening. And then similar in improvement and learning, it's kind of director led that they disseminate the information that we gather to organisations that can make improvements in these areas. So pharmacy, CAMS, access to adult social care services, information support for people living with dementia and their carers, and digital access to health. So those are the areas that we're looking at under improvement and learning. Let's go down. So focused reviews. These are our projects. So we're looking at corridor care. I know Chris is looking at that. We've got patient and carer experience of living with a serious and enduring mental health condition. We've got a big project on that, which Rowan, our engagement officer, is working on, which will be due out later this year. We had the education, health and care plan survey last year, and we're going to do a follow-up survey this year to see if anything has changed. Prevention and early diagnosis of cancer. We've got Chris, who is working on the prostate cancer and having a closer look at provision around accessing diagnosis. And then support for people receiving care at home, including end-of-life care. Our director, Julia, is leading on that. So we've got some cross-cutting priorities. So these are sort of threads that go through all of our work. So we've got health inequalities. So we're always trying to target people who may not be able to access health and social care services. Supporting carers. We are always listening to carers and taking on their views. Safeguarding and protecting vulnerable adults. We're always on the lookout for anything that comes to us that we think we should be raising concerns with other organisations. Working with volunteers and community groups. We do that. We have a volunteer network and we have our reference and engagement group, and they all, everybody in that network gives us a connection to specialist areas of the community. Then we've got accessibility and inclusion. So we want to remove barriers to people giving us their experiences, and we're always working on that. So then the last page, because it's only 4 pages, is objective 4. And this is about closing down Healthwatch Worcestershire and making sure that the work that we have done goes on to inform whatever comes after us. So we've split this down into 4 areas: access to data, insight and learning, supporting sharing of knowledge and system legacy, future delivery for Healthwatch functions, and closure and transition planning. So our plan is that we will close as Healthwatch Worcestershire on the 31st of March. We haven't had that confirmed, but that's what we're working to. Until then, it's business as usual. And then after whatever comes after that, it could be a transition, it could be a completely new service. We will endeavour to make sure that it is informed by the work that we've done up to that point. So that's our new business plan. You can find that on the website under the public board meeting page for today.
Could I just make a comment on that?
You certainly can.
Thank you. We've seen the health modernisation bill begin its progress through the House of Commons from the King's speech and summary that was sent around by Debbie, which was very useful to read. In there, I read that they were talking about transition boards. So I think one of the next steps towards the end of health watches across the country is setting up transition boards. Now, what that looks like or who's going to be on them, don't know, but just thought I'd better put that in there while we're talking about what the end looks like. So I think that means really that as the information becomes available, we will let people know. And that's the first thing that I learned that was new this week. Thank you.
Thank you. Any other comments or questions regarding this matter? I mean, personally, I found this exercise of going through the business plan really helpful to refocus and go through and make sure that we're actually looking at the right areas and we're concentrating our resources in the right way over the next 12 months. So I think this process has been really helpful. yeah, just to work out what are the most important issues, and what should we be putting into using our resources. So yeah, I found the whole process very helpful. Any other comments before we move on?
Hazel's got her hand up.
Sorry,
Yeah, I was just going to say, sorry, I was
sorry.
just going to say it looks like quite a lot of work. I mean,
Mm,
just to comment really that given that it's a year to achieve that and that the organisation potentially is winding up, it looks like a lot of work. So, but you know what you're capable of, so good luck.
thank you. Well, it's always good to stretch, isn't it? The worst thing we could have done would have done an easy business plan, and yeah, easily achieved it. So we like a bit of a stretch. Any other comments? Okay, I don't see any other hands. We're now moving on to prostate cancer project. Chris.
Right, so let's see if I can share this. Let's have a look. Share. Not that familiar with Zoom. Can you see my screen?
Yes.
You can. Excellent. Right. Okay. So, hi everybody. This is a follow-up survey that we conducted, following up from previous reports on PSA testing and prostate cancer last year. We wanted to find out if things had changed, basically. So the short answer on that is no. The long answer is in the report, so please go and have a look at the report. What I've done here is I've summarised it as themes. I'll just briefly talk through those, but I wanted to mention Phil, who I sat down with and did my first ever podcast, which I learned loads of lessons on how to do that. And the engagement officers were able to chop that up into useful pieces and broadcast it through social media. And they succeeded in reaching over 3,500 views, which I think is tremendous and shows the power of social media, and obviously should be used in all our reports going forward, I would recommend, because that's the way to contact people these days, and it just works. There is a link in the reports to the full podcast if people want to look at it as well. So please take time to do that. It's quite interesting. Phil has been very generous to give us permission to use his story, and how he was diagnosed late. And that's part of the problem when it comes to prostate cancer, because over 50% of patients are diagnosed late. That's one of the themes that continues to come through. And part of that is around men and their families being uncertain about what their risk levels are. So anybody listening to this, if you have any concerns about what your risk level is, please go on to Prostate Cancer UK website, and there's a risk checker on there, and it's very easy to actually work out what your risk level is. It's all about family history and the like, so that is definitely worth doing. The third theme that we confirmed basically was there's a reliance on informal awareness. So it's what your mates tell you about prostate cancer, PSA testing, what people find themselves when they go and do sort of their own personal research. So that's where a lot of men tend to go. So that begs the question, really, what sort of support do they get from their GP? So there are some really good GPs out there, and we've highlighted, well, we are aware of a number of very good GP practices within the county. We're not allowed to actually say who they are, but they are out there. We also are aware there's variation in access to GP support, and that starts from when men and their families approach the desk at their GP surgery. It depends who's on duty and what training they've had, all the way through to they get really excellent support from their healthcare assistants, GP nurses and GPs. So that brings us to gap number 5. There's gaps in information at key decision points. And this is the feedback that will be fed back into the system. And it appears to be not just common to Worcestershire, it's common across the country as well. And the final thing I'd like to say on this is that we are still awaiting the UK National Screening Committee final report on whether they're going to go behind prostate cancer testing or not. Early indications are they're just going to be looking at the identification of men who've got a genetic high risk, BRCA1 and BRCA2, and the detail around how they're going to do that remains to be seen. So I'll stop there. Any questions, please? Silence is golden.
Chris, did you see any improvements across the county between the two reports? Is there any shift is there any good news really? I mean,
there are more men reporting better contact with their GP surgeries, so it is moving. The other thing that's happened, of course, and it's in the report, is that the Hereford and Worcester ICB have set up some programs as well, which are going to drive improvement in this area as well. It's all very local. They put what they call a local enhanced service in place, and there's also, I guess you'd call them preventative screening communications that have been sent out through social media from the ICB board as well. So these things are happening. So there are movements. It is positive, but it's slow. And the problem, of course, is that you want men to be identified at stages 1 and 2 rather than stages 3 and 4. And that's where we currently are at the moment. But the direction of travel is good, albeit slow.
Lee, would you like to answer?
I was just going to say, sort of related to it, that with the obviously the prostate cancer, it seems very in line to me how women feel they experience when they go to the doctor about menopause or other certain specifics where it's like a hit and miss with GPs. Some are fantastic, some are okay, some are awful. And I just wondered, because obviously we've been involved in the Core Plus 20 about obviously women from South Asia and again how they experience it. And part of that project was to sort of put information together, obviously for professionals. And I just wondered, as part of maybe a little project we could do, is maybe put the voices of survivors or people, even people that didn't actually have it but thought they did, and put it in like a little, almost like a little training package of the voices of the people that have experienced GPs. And I just wanted like a little, almost like a little storybook of good practice, bad practice, okay practice, and the impact it made on them psychologically and confidence-wise. I wonder if that is something maybe that we could do, because I do believe, even though lots of times GPs keep saying they've got a bit of training, it's so different from each surgery, each GP. And I just wondered, sometimes is that something that we could potentially do? Because I think it's very powerful, because as much as we can do a Healthwatch conference so we can get the top dogs there and we could do certain things, actually maybe having just a little pamphlet, a little booklet on people's voices, and not necessarily telling them what procedure to do, but actually just letting them read those experiences of how people participate and feel it. I wonder if that would be a powerful tool aid for a learning aid for them.
It's certainly worth thinking about, and maybe I'll speak to you offline about that, Lee, because I think
it doesn't have to be costly. It doesn't, just people's voices. It's almost like a storybook, a prayer book of people's experiences, just sent to every single GP, just to read and digest and maybe reflect on their behaviour and how they treat individuals when they came in with those concerns.
Well, we've certainly seen from talking to other local charities that other cancers are also experience this variation in response as well. So I don't think it's an unusual situation. I guess it's a case of how variable is that response, in the county as well. I know that Abby has been phoning a lot of the local cancer charities, and I remember a conversation with her about exactly this point. So the question, in my mind, Lee, would be, what's the best way to get that into GPs' heads? What's the best mechanism to do it? A booklet sounds good. Who's going to read it? And, how do you get that change behaviour into a GP's head when they're busy?
Then what happens is you just get organisations like mine, community venues and different types, because obviously we've all got different areas. Get it printed, very, very quarterly, cheap. It doesn't have to be something expensive. It doesn't need to be big, massive, long stories where they're going to switch off. And then we contact the GP surgeries, and obviously, they're packaged, or we just drop them in, and each GP, we name it. It's in an envelope. It's given to them. We can't lead a horse to water, but if it's there and it's in front of them, there's a high percentage that are going to just do it. And as long as we're getting through to some, I'd like to think, have a bit of faith that they would listen to those voices.
Okay, Vicky, can you put that on the agenda for the next closed board meeting, please? Thank you.
Yeah, will do.
Thank you. Thank you, Lee.
Any other questions or comments before we move on? Thank you. Chris, again, on temporary escalation spacer update.
Yeah. Okay, let me share the screen again. Can you see my screen?
Can we yes.
There we go.
That's bigger and better, yeah.
Is it? Okay, that's cool. Yeah, I'm not that familiar with Zoom. Right, corridor care is obviously something that's in the news all the time at the moment, and nobody wants it. We don't want it. Patients don't want it. The NHS don't want it. It's a reality of the pressure of numbers going through the system. So I thought it might be useful just to give a where are we now situation report. So that's what this is. So I thought the best place to start would be to look at what the actual current guidance is from NHS England. So you'll see here that back in December 25, they produced a report with some principles for providing patient care in corridors. So I picked up 4 points. There are more in the report, but I just picked out the ones that I thought were quite impactful. But the first one is that corridor care areas must uphold the same high standards of care for patients as those in planned clinical non-corridor settings. So that's the challenge to them, is that they've still got to have the same degree of care than they would do if they actually found themselves in a bed on a ward. Patients should be allowed visitors in line with local visiting policies in the area where they're being cared for. Now, Rosemary Smart from the Patient and Public Forum and myself did a site visit at the Alex and at the Worcester Acute emergency departments. And we saw the patients in the corridors. These are not ideal. But it should be known that if patients find themselves there, that they are allowed visitors and that they should be asking for them, because obviously it's all about patient welfare, and the best kind of welfare that you get is when your friends and family come and visit you. So they are entitled to that. Patients should be instructed on how to alert staff to their needs. So in the Worcester Acute, they have 2 full-time care assistants whose job it is to monitor corridor care patients. So their job is to just go and talk to them, make sure they're okay, and basically notice if they need any help with anything. Now, obviously, because people get busy, Sometimes they may miss things, that's just how it is, but that is their job and that's their purpose. At the Alex, they have bells. They have some kind of, I think it's a bell or a buzzer that the patient can actually use to ask for help. And they also have volunteers at the Alex as well, that their job is just to go and talk to these patients in the corridors, to make sure they're fed and watered, and they talk to them. And I saw that in action, and the volunteers are highly motivated. So they're doing what they can. Patients and families should also be encouraged to raise concerns or complaints in real time. So if there are issues, the best thing to do, like a lot of things in life, is complain about it, talk about it when it happens. That's the best way to get things done. Sorry about all the words on this slide here, but as of the 4th of March this year, NHS England wrote to all trust CEOs and chairs. The first thing that they said was corridor care is unacceptable. Nobody's pretending that it is. Corridor care is also known as temporary escalation spaces. Other terms used include words like planned escalation beds. So if you hear them, it's all talking about the same thing. Feedback from Corridor Care Coalition. So NHS England have put a team together to look at what they can do to reduce and improve what happens when it comes to patients in the corridor. So I've picked out just a few things here. There are more in the report, but I thought these ones were particularly worth talking about. So there's recognition that the staff are having to deliver care in non-designated areas impacts the staff as well. They don't want to do it, but they have to. And of course, it impacts them as well. So it's important to actually recognise that. They've got a definition for corridor care. So the definition is if a patient has spent at least 45 minutes in clinically inappropriate area of an emergency department or a general and acute ward, that is corridor care. So the directives include transparency on patient experiences and transparency on the staff experience as well, having to deliver care in these non-designated areas. There's increased prioritisation of eradication of corridor care. Trust boards will now formally take ownership of corridor care as an organisational risk, and improvement plans need to be done at executive level. I don't think that was always the case before. So, they've made it now a clear priority. Getting it right first time improvement guide on corridor care is due to be published fairly soon to help them with this task. So what's happening in Worcestershire? So Worcester acute hospitals plan to begin reducing corridor care spaces, beginning with the medical spaces now, and they are reviewing surgical spaces in June. They're starting with the medical same-day emergency care, and the Laurels ward will have planned escalation beds as part of a full capacity protocol. And they plan to reduce these by 2 at the moment. So it's only a small number, but it's a start. So they have made a start. And the other thing to bear in mind is that patients also receive a patient information leaflet, which explains why they are on a corridor space while they wait for a suitable bed space. Now, I've got the actual letter here. I'll just pick out a couple of bits of it. So this is what the patients actually get when they find themselves in a bed on a corridor. So it says, you may be aware that the local and national news that the NHS is under incredible pressure within hospital emergency departments, wards and ambulance services. And we are taking steps to help manage this and support our local community. This means that if there is a delay finding a suitable bed space for you on a ward, you may be moved to one of our corridors within the ward, at the entrance to the ward or in a temporary space. This could also happen if your condition improves. To help us find beds for the sickest patients, we will continue to prioritise your safety, privacy and dignity at all times. During this time, you will be cared for by nursing and medical staff for that ward area, and you will be provided with meals and facilities as required until a suitable bed space for you is available. And the final bit is, we will only move you once a nurse and a doctor have assessed you and agreed you are suitable to wait in that area. We found that this makes your journey from the emergency department to a ward much quicker. And that's signed by there's some more words as well, but that's the key bit. And that's signed by Stephen Coleman, the Acting Chief Executive Officer, Hayley Flavel, Chief Nursing Officer, Chris and Douglas, Interim Chief Operating Officer, and Dr. Jules Walton, Chief Medical Officer. So, on the final slide on this is have your say. So, if you want to tell us about your experiences, please do. And the way to do that is to go onto the Healthwatch Worcestershire website, go onto the Get Involved tab, scroll down to Have Your Say, and there's a permanent survey in there that you can fill in and talk to us about it. So I'll stop there and open to questions.
Hazel.
Sorry, I'm trying to find the Zoom mouse. I was intrigued by the two members of staff that are specifically there to support patients in corridors. Is that a 24/7 thing, as in there's always two members of staff there 24/7, or is that?
Yeah, I think so. I will clarify that. I've got a follow-up visit on the 1st of June with them. I will find that out. But when I was there, they were certainly there on station, and they had all these letters and everything. And I know that things do change at night time. So it's a good question. I'll confirm that, Hazel. Yeah.
Having supported someone who was cared for in the corridor in A&E, my suspicion is that that's during daylight hours, not during evening hours. But yeah.
Yeah. Okay.
Debbie.
Do you know if there's any plans to introduce call bells in the Worcester Acute?
I asked specifically that question. The answer was no. They feel that the care assistants that we've just been talking about are more than adequate to do the job.
Right. Okay. I mean, obviously, you're aware of my experience over the last few months of A&E.
Yeah. Yeah. Exactly.
I would also, go on.
Sorry, go on, carry on.
I would also challenge the sentence where they're sort of encouraging people to raise complaints in real time, because that then becomes another problem in the fact that it's actually finding somebody that will actually deal with your concerns.
Yeah. So I think that's where we need to hear the real stories. So I think clearly try and get any questions or needs sorted in real time. That makes perfect sense, doesn't it? If that doesn't work, then talk to us about it, because I can go back and say, look, here's the examples that we're getting, and if you say you're doing something and you're not, then you need to change it. If you say you're doing something and one member of staff isn't doing their job properly, then you need to deal with that, and so on and so forth. So I think to have your say option is quite important here, because this is a live, crucial topic for a lot of people, and they need to get it right.
Thank you.
Lee?
A little bit, I suppose, on top of what Hazel said, really, it'd be good to have a bit more confirmation, because I know when you said, Chris, you did a visit, but I presume just like this one now, it was a planned visit. And the thing is, when they're planned visits like that and you see it working really well, I mean, I run my own centre. If you told me you were dropping on me tomorrow, I'd make sure everyone was in here. So I think making sure that people are aware, because I also, due to heart disease and numerous heart conditions, and a daughter that also has special needs, I'm frequently, unfortunately, in A&E. And I've regularly seen corridor patients in Redditch where I've been in there for 10 hours plus in A&E, where the corridor people are left with hardly any visits or hardly any catch-ups. So I would like Hazel said, how frequently are there? Is it recorded? because I regularly see them without drinks, food in there for a long time. But the other observation I would also like to say is, regardless if we like them or not, I also understand their necessity for being there, because obviously it's an overwhelm. But I'd just like to think somewhere, I've noticed that a lot in the corridors at times can be older people. But they also can have quite a lot of triage coming through with patients that are presenting with drug and alcohol issues or significant mental health issues. And they could be very much next to two older people. And I always think of obviously my background with mental health here, that when someone is in any shape or form not very well and not able to potentially move or protect themselves, being left next to somebody who potentially could be in a mental health crisis, I always find that a bit uncomfortable at times, because, you know, as whilst the people presenting with those issues still need to be cared, I do believe that having them right next to somebody that doesn't have the ability on lots of occasions to be able to speak or to ring a bell or press a button, I think sometimes how that's triaged and looked at could be better when you've got such vulnerable people together, that some sort of triage there could be more appropriate. And then also it says that visitors are, you know, should be encouraged in the same line as obviously for people that are in beds or suitable. But again, that's also in reality doesn't work, because I mean, I'm only talking about Redditch because I'm in there. They are in a small corridor that people, the ambulance crews are walking past, paramedics when they're coming through. You've got recess at the bottom. There's loads of things. There is no appropriate seating. Now, if you were sitting there saying to a relative, you know, stand by the side of the bed for about half an hour, maybe, but you're talking about hours and hours without appropriate seating. And a lot of those older people in there have older relatives as well. And I don't think that, whilst they say they should have access to visitors to help them, there's nothing there to help them actually be there.
Yeah, I mean, I agree entirely. As I was going through the ED department at Worcester, it was a level 4, so it was a busy day for them, and we did ask if we should just go home and let them get on with it, but they said no, you can, you know, stay, as it were. They were very busy. Ambulances were queuing up at the door to come in through the back door as well. There were patients in the actual waiting room as well, just getting more and more patients in there. They coped, and I think that's the issue here. You know, they coped. Part of this equation, which we've not really spoken about so far today, is the flow through the hospital, and the other part of this is the discharge, because obviously patients need to be moved out of the wards and out of the hospital in order for the patients to come off the corridor care beds and move into the wards. And they are doing quite a bit of work on that, and I'll be talking about that in a second on my next presentation. But, you know, they are aware of it. It is unsatisfactory, there's no doubt about it. And you're quite right, there are no chairs for patients next to these beds.
I've just had to spend a large portion of my time in 2 hospitals recently. That's why I've been absent for a while. In Glenfield Hospital in Leicester and Northampton General Hospital in Northampton, between the two. And they've got really well established departure
discharge lounges,
rooms, and they're really set up. They're nice places to be in. The seating's appropriate. So rather than being in beds, even though they know they've been discharged that day and could be there all day, their beds are freed up, and they are. It's not A&E type thing. It is definitely, but the nice seating. It's appropriate. Got television. The food is still brought in. The nurses still walk in to check on them. But those beds are released, and I thought that's a really good setup in how the moment they're saying they're going out that day, they're put in there. and that bed's released as quickly as possible. Because how many times, you'll find you've been told to discharge that day. You could be at 6 o'clock in the morning, but you could still be there at 7, 8 o'clock at night, especially if someone's waiting for transport. So I thought that is a really good use of discharge situations. And I don't know how Redditch or Worcester utilise that well.
Yeah, they've got a new integrated discharge team, so they are looking at it.
Yeah, but I mean, actually, not so much the team, because you can have a team, but what they can have a team as much as they want, but where they got, and it's an area that's utilised well, and the patients don't feel like they've just been dumped back in A&E. They can see it's a step down. It's not A&E, but it is a good use of getting the beds back into play.
Thank you. Hazel?
I suppose my point was going to be similar to Lee, which is that we've heard recently about a family, a SEND family, who've got an autistic young adult who sat in the corridor having epileptic seizures for quite a long duration. And I just wonder whether there was, when they're triaging who's in the corridor, whether consideration is taken for protected characteristics that might mean the impact of that corridor care is greater for that person than your average.
Yeah, the two ED departments, when we were being taken around by the matrons, showed us rooms where patients could actually have a quieter experience and taken away from excessive noise and so on. But obviously it's a capacity issue as well, isn't it? So they do have areas for that, Hazel. So
just in this situation, the young woman was sat in the corridor for over 12 hours as an autistic person having seizures.
Yeah, which is unacceptable, clearly unacceptable. And was a complaint made about that,
We held an event recently where the engagement officer, the patient experience lead, is it Hayley? I can't remember, from the trust came along, and that experience was shared directly there. So
yeah. And I have to say that the contact that we've all had with Hayley, the chief nursing officer, is being really quite positive. She's determined to change things. She's fairly new in post. She's saying all the right things, which is the start. So.
It was Anna Stirk. Anna Stirk that came along. So it's been shared. Thank you.
Yeah, good. Thank you.
Any other questions before we move on? I'm just shocked, really, how all of this has become so normalised. Something that was brought in short term has become, now the fact that we've spoken so long on it, it's become sort of the norm, which is shocking, really. But I'm sure we'll be coming back to this subject in the future. So thank you for that discussion. Moving on, the future of Healthwatch. As Chris was saying before, we've known for some time that there were plans to change Healthwatch. It was talked about at the King's Speech on the 13th of May. That was the first time it was officially raised. It had its first reading. The health bill had its first reading on the 14th of May, which was no debate. It was just raised as one of the future bills. Healthwatch is a small part of that health bill, with all the reforms that are going to be going through there. The second reading will be on the 1st of June, at which MPs will be able to debate and vote on the overall principles of the bill. And again, Healthwatch is quite a small part of that. There are no signs at the moment whether that the bill won't go through to the second stage. It looks very likely. So when it goes to the second reading, MPs will be appointed to a committee with a government majority to consider the bill in detail. And then at that point, any amendments, any changes to the bill will be made. The bill confirms government plans to transfer the statutory function of Healthwatch England to the Department of Health and Social Care, and it also transfers all the functions of the network of 153 local Healthwatch bodies, of which we are one, to integrated care boards and local authorities. Until legislation passes, Healthwatch staff and volunteers across England remain committed to fulfil their statutory duties, and in Worcestershire we are no different. We are continuing in our work. A statement by the government says putting patients at the heart of care means devolving decisions to a local level. So those who truly understand the needs of their communities are trusted to shape and integrate services more effectively. And by implication, that is ICB boards and local authorities. But what that actually means at this stage, we don't know. We haven't been told. What we are doing as a Healthwatch Worcestershire, as you've seen this morning, we've reviewed and adapted our current business plan. We are working on a formal exit plan. We want to end with good governance, and we are committed to that. We are looking at all the options post Healthwatch, and discussing that as a board. We are attending meetings that discuss the future of Healthwatch, or the organisation that replaces Healthwatch, with the Department of Health and Social Care and other local Healthwatch organisations. And we're involved in trying to shape what comes next within Worcestershire. And it's worth remembering that the new ICB, which will be within the bill that's going before Parliament. The ICB that will cover this area will cover Coventry, Warwickshire, Herefordshire, and Worcestershire. So it's a massive footprint compared to the ICB that covers Hereford and Worcestershire at the moment. But how they actually perform the functions that we currently perform, that is something that we do not know at this moment in time. But as that picture becomes clearer, we will obviously try and get that inform all board members. So, any questions? That was a quick run through. Or comments?
I was just going to say, obviously, as a board, obviously you're talking very much about obviously where the statutory obligation and where that hangs. Is the board got any plans? Are you independently looking at sort of survival in a different guise? If that's the case, whether that's a lottery grant or whether having conversations with Worcester County Council, is there anything that you are considering doing in your own right? It won't be Healthwatch, but the same services, but obviously as some sort of health watchdog yourself. Is there any plans, or is it definitely, if there's nothing for Healthwatch, then it ends when it ends? What is your plans?
all options are on the table, and we are considering all the options available. But as far as Healthwatch Worcestershire, that we are told that will end on the 31st of March 2027. What comes next is something that we are looking at that and trying to use our contacts in the ICB and local government.
What I would suggest is not waiting till the end is here. And obviously, as a board, as an entity, obviously it's going to be perceived as self-serving in lots of ways. For people to dismiss it as, oh, you just want to be here, you want to survive and whatever. So wouldn't it be good maybe in this period of time, whether it means anything or not, that rather than just us as a board keep going to the ICB or people like mine to say, look, we should be here, that we actually do get some support from other organisations or, you know, the whole sector to sort of support that. So it isn't just us because we've got a vested interest in it. So obviously as a charity, you know, that you look at how many VCS organisations that are in there. So wouldn't it be good maybe to get some letters of support or even feeling, you know, for an equivalent of Healthwatch to help support it, that even if it's a case of that without it, you know, that the third sector would have obviously some concerns, whether some of these patient groups that people visit all the time, can we get some testimonials, can we get some support from those, just to say that the lack of confidence that their voices will be heard. And it just, and whether it might mean nothing and it may not come to nothing, but I do believe while we just go on our own and we go and have closed meetings with the ICB and like-minded people, they're always going to look at us as a single entity that have got something to lose or gain. Whereas if we talk about a whole community of people, and I think it's making sure that the distrust comes from all community groups, not just Healthwatch itself. I think don't, you know, let the power of the people speak, if that makes it sense. Let people like, you know, Hazel knows with all her community, you know, people like mine, you know, I specialise in mental health, but also for people who are quite oppressed. It's all right for people that don't fit into those sort of nice, easy cohorts of people, but for other people a reality is they're not going to have a voice that's going to be checking out for them. That is, you know, and when we look at oppression and we look at things that we go through, you know, who is going to be their voice? So it's utilising those organisations to come out and support you or us. You know, obviously I'm a co-opted member, but, you know, let's not wait to the end. Let's get it so it's here now. Start doing it now. Start getting that support.
We're certainly not waiting to the end. I mean, I think that's very.
You've got a period of time to get a sizable amount of support in written form.
Yeah, we will certainly look at that and take what you've said and and look at how that could be utilised in an appropriate manner.
Yeah.
Hazel.
I suppose my question is a slightly practical question. Do you even know who you're negotiating with about what the future model looks like in Worcestershire for this? Do we know who we're talking to? Because that's sometimes half the battle with the ICB at the moment is.
Yes, we are talking with the ICB, and it is the sort of top tier of the ICB.
Okay.
And same with local authority. Having said that, obviously there are changes happening within local government, so that may change. But certainly with the ICB, it's at chief officer level.
So one of my comments would be that you know, there's a lot of goodwill for Healthwatch in the SEND community now because of all the hard work that Debbie and others have put in. So that's definitely available to be leveraged as per Lee's description. And also, given the recent Ofsted re-inspection, etc., of which they've not published the outcomes, this whole marking your own homework concept is very topical. And actually, I think we could ride the Ofsted wave potentially a little bit of that as well, because they've had the message loud and clear. And that kind of concept of you shouldn't be allowed to mark your own homework is very much ringing in their ears, kind of thing. So,
I mean that message has been put to the powers that be, Department of Health and Social Care, and their reply is very much the government has decided, and their role is to carry out the wishes of the government in power at the time. It's a very politically driven, and if the government decides that Healthwatch ends on the 31st of March, it ends on the 31st of March. What replaces it is the thing that we are now trying to work through and trying to get what is right and what is appropriate for the people of Worcestershire. Yes, it will be Coventry, Warwickshire, Worcestershire, and Herefordshire, but we are trying to concentrate on Worcestershire at this moment in time. But we're also having to look at the other areas as well, because that will be the footprint of anything that replaces Healthwatch. The 4 health watches that are currently in place will disappear and will be replaced by one organisation or one
and presumably
supplier.
you're talking to the health watchers in those other areas where the new cluster ICB is formed about potentially working together to pull across and cover the whole of the ICB footprint.
We are having meetings, yes. Any other questions or comments from the board? Thank you. We are now moving on to the next section. Vicky, Worcestershire County Council Contract Commissioners and Performance Report.
Yeah, thank you, Don. I will just share my screen again. Okay, just making sure you can see that. I've got strange Zoom boxes all over my screen. So
Yeah,
can you see that okay?
we can see it, but we've got little black boxes on it as well. But
I'll try and move this over because I need to put it. Is that better?
it hasn't moved, but we can still read the actual written report.
Okay, thank you. All right. So yeah, so this is our Q4 Commissioners report for the end of the last financial year. We have already presented this to the commissioners, and going forward, we want to bring this to the board meetings before it goes to commissioners. So we have spoken to them and rearranged our meetings to make sure that the timeline is the report comes to board and then goes to the commissioners. So I just thought I would mention that. So the last quarter, I'll just go through the executive summary and maybe look at some of the figures. So obviously we've mentioned we've redone our business plan and added our strategy on there. So it's been finalised now and hopefully, well, it's been approved today. So we're going to make it look a bit prettier and get it up on the website and send it out to the commissioners. So the key highlights, recruitment. So we recruited another engagement officer, Rowan Grigg, who joins us today. She's doing the minutes for us. So thank you for that, Rowan. So now we have a full team of 3 engagement officers. And we did a lot of training. It was cold, dark winter months. So we did a lot of training on the website, the signposting, communications and social media processes, and other mandatory training, including safeguarding, those sorts of things that we need to be trained in. So our face-to-face figures were lower than they would normally be. However, this quarter we're making up for that. So they've been out quite a lot, the engagement officers, over the last weeks. When I reported this, we were 3 weeks into April and we had 122 face-to-face contacts, but I know it's a lot more than that now. Reports-wise, the Parent Care and Needs Assessment Report was published in Q4. And then we had the Prostate Cancer Report, which, well, it was due to be published at this point, but we've just seen that today. The Healthwatch abolition, we gave them an update on that because surprisingly, the Commissioner at the County Council doesn't really get any updates from anywhere about what's going on with Healthwatch. So every time we go for our quarterly meeting, we update them on any information that we know. So they're getting all their information from us on the wind down of Healthwatch Worcestershire. Chris has mentioned we did a podcast with a stage 4 cancer patient, which has got over 3,000 views. And we've got another podcast now in production for this quarter, which is around sensory impairment. And we've included some of our volunteers, and we've done interviews, and that's just going into the edit shortly. So obviously we've had our public board meeting, the one in January. As you may remember, we had CAMS along to that and other representatives from the Health and Care Trust. So we advised our commissioners that we had been doing that. So we have had a drop in volunteers. So we've been looking at our volunteers, contacting all of them, seeing if they'd like to stay with us. So out of 18 volunteers, we've retained 11. So we've got an engagement officer, Abby, who is dedicated to our volunteers now. Plans include a web page, and obviously we've got 3 of them involved in the podcast, and we're going to look to get some of them out at events over the summer. Overall, these are our performance figures. So we've had 149 people last quarter contact us for signposting, advice and patient experience. Just over 3,500 website visits. Over 1,000 people have signed up to our newsletter. 94 members in the reference engagement group. I mean, that's gone down by 3 members, but I think given the circumstances, we're very honoured to keep our 94 members. And then it's probably gone up a bit now. We've got about probably 1,300 followers on the Facebook page. So I've been through a lot of this in the summary, but I just wanted to pick up on KPI 4, which is our public contacts. So we were asked to include a new measure, which is signposting complexity. So we talk about how many contacts we've had, the channels used, so you can see those listed there, the inquiry outcomes. So do they just want information, or are they providing a patient experience? And then the signposting complexity. So if somebody comes to us and they want to know where they can go for a certain issue, we had 149 of those last quarter. You can see here the majority of them only took around 2 hours, up to 2 hours, but we did have 3 complex cases which required more than 8 hours of engagement officer time to sort. So I just thought that was worth noting. A lot of this has been mentioned in the in there. So I'm just going to move this bar, and then so here is some of the breakdown in the appendices of the figures you can see there. So we've got the complexity added on here. Performance, equal ops data. There's no big surprises in there really, but I did want to raise this at today's meeting, which is a customer satisfaction responses. We haven't gathered previously very many customer satisfaction responses, so we used our digital channels to ask people what they thought of our service, and we did get a response. So overall, it's excellent. We're very pleased that people are finding our service useful and professional. I also wanted to show you some of these amazing comments about Debbie in many cases, because the knowledge that our team have is second to none really when helping parents, parent carers find where they need to be. And also Debbie has been advising, I think she's been non-stop, haven't you, Debbie? With this work. So yeah, so there's lots of praise for her there. I mean, we've got some more general comments there, which could be about the engagement officers as well. So we're going to continue to collect this, not just to sing our own praises, but also to learn what people need from us. So I think that really concludes the Commissioner's report. Is there any questions on that? Nope, I can't see anybody. So Thank you.
Sorry, Vicky. Just a quick question. I should have asked you this previously, but have the commissioners actually mentioned about the end of Healthwatch at all?
No, they don't have, as of the last meeting that we've had with them, they don't have any direct information coming to them from the Department of Health and Social Care on what the next step is. So any updates they get are through us. So, I mean, to begin with, I don't think they really realised how many statutory functions they will have to take on if they remain. So, I think there's a meeting in a few weeks with the Department for Health and Social Care where they will be outlining some transition or arrangements, which then we will feed to Matt Fung, our commissioner, because I'm not sure he's being invited to any updates from the government as of the last meeting we've had. So I'm assuming the ICB won't have been updated directly either and is just getting information from us, but I don't know that for sure. So
Thank you.
Any other questions or comments? No. Move on then to item 6. Healthwatch Worcestershire's response to quality accounts. Worcestershire accused the first one, Chris.
Yep. So there you are. Can you see my screen?
Yes.
Perfect. Okay. So again, I'll take the report as read. So what I've done here is I've summarised it. I'll just walk through that. So on the right-hand side, I just actually lifted this from the Worcester Acute Quality Accounts because it's quite a good overview of the trust itself, the area that it covers, numbers of population that it actually serves. Of note there is the fact that the population will be growing quite significantly over the next few years. There's new housing estates everywhere, as we all know. And obviously around the Worcestershire Parkway, I think, isn't there going to be a new town there or something like that? So that's a hell of a lot of people for the existing hospital services. So it'll be interesting to see how that one pans out. So what I've done on the left is I've just picked a few highlights from the report. So the big quality conversation and the patient and public forum are good examples of where the hospital are listening to the public, and they can show that they are doing that. There is a reduction in the number of complaints. I think the figure's something like 14% reduction going through Anna Sturks and the PALS team. Whether that means there are less complaints or people just don't bother is obviously up for debate, but we always recommend, as you've heard previously, complain if you're not happy, do it in time if you possibly can, or come to us and let us know what's going on. That's always a good thing to do. They understand that the discharge element of the patient flow through hospital is critical to get right, so they've set up a new integrated discharge team with the job to put all the functions together to make sure that when patients are medically fit, that they actually can leave the hospital, there's transport in place for them, and there's a place for them to go. So there's lots of complexity behind that, but they are actually looking at it. And again, I'm talking to them specifically about their discharge. So if there are any stories that I need to hear about it, can you please let me know? Also, as part of that, they are looking at how to communicate to the public so people only go to the emergency departments when they need to. There are other avenues patients can take. So, for example, 111, minor injuries units, their GPs are now putting in surge hubs so that there should be more appointments available at primary care level closer to home for them. So there's a communication plan that's needed, and hopefully they're going to be doing that to persuade more people to only go to ED where they possibly can. As part of that, I'm also aware that they've identified high intensity users of ED. So there are a number of people who seem to enjoy going there frequently, and they've identified who those people are, and they're trying to engage with them to see if there's a better solution for their needs. So these things are being looked at. I've commented already on the corridor care reduction planning. They've also put together a communication passport, which has been co-produced with patients. The idea behind this is to make patients' needs more explicit when they go through the system. So we know that patients don't like telling their story again and again, and this is one way to try to minimise that. Again, I'd like to understand if this is being used consistently, if it is making a difference. So again, if there's any feedback on that, can you please let us know through the usual systems? They've also put in place a new individualised last days of life care plan. It's all about the dignity. If you're going to die in hospital, most people tend to not want to die in hospital. They want to die at home or in a family setting. And this is all about trying to enable that where possible. One of the areas that confused me in the quality accounts that they've written is about sepsis. So we're pleased that they are still focusing on sepsis. They're putting a new pathway in place for it, but they've paused formal reporting on it. So I've commented on that in the report. You'll see that in there. We've also requested progress on Oliver and Gowan Tier 2 training. The report said they were good at this, but when you unpick it a little bit, you find that they're only actually talking about Tier 1 training. And Tier 2 training is where the effort needs to go. So we've commented on it, and we'll be following that up and asking them to actually provide examples of where that training is done for the list of healthcare professionals that they've previously identified needs Tier 2 training. We've also requested transparency on senior and medical surgical vacancies and the impact that has on fragile services, for example, dermatology, urology, maternity and breast come to mind immediately on that. So I'll open it up to questions, and then we need to approve the report for publication. Thank you.
Questions, comments?
Stand into silence, which is
Yeah.
a good thing, I think. So can we approve that for publication, Don?
Yeah. All those approve, can you show your hands?
Thank you. And I forgot to do this for the prostate cancer survey report as well. So we need to approve that for publication again. So can we have a show of hands on that as well, please, if you're happy with that? Thank you.
Good. Thank
And the next bit I need to show, can I just do the West Midlands one as well?
You can.
Let me just share that. Hopefully that'll come up. So can you see my screen?
Yes.
Yeah, okay. So we've also been asked to comment on the quality accounts for the West Midlands Ambulance Service. So that's being written at the moment. We've got a draft reply already written. So we're going to be focusing on the priorities that they identified from last year. Did they do what they said they were going to do last year? That's going to be the basis of the feedback. And just for interest, I thought it'd be quite interesting to let you know what the priorities for the West Midlands Ambulance is for next year or the coming year. So you can see the 4 priorities there. So it's all about reducing hospital handover delays. And they have made some improvements on that already. I think that they're aiming to reduce it quite significantly. Clinical supervision review, improving clinical care by the use of patient safety incident response framework, priorities and audits, and to develop clinical models of care. We've also been in contact with the other health watchers in the cluster, so Herefordshire and Warwickshire and Coventry, and we've asked them if they would like to contribute to the quality account so that the West Midlands Ambulance Service gets a rounded Health Watch response rather than just Worcestershire. We've had comments back already from Herefordshire. Warwickshire said they are going to comment on it. I haven't heard back from Coventry yet. So hopefully by the end of this week, we'll be able to complete the report and bring that to people's attention for agreement and publication. But I just wanted to let you know where we are with that. So this is to follow. Thank you. Stop there. Any questions, comments on ambulance service in Worcestershire? Back to you, Don.
Thank you. Moving on to the Health and Care Trust quality accounts. Vicky.
Hello. Yeah, so I'm presenting this on behalf of Julia, who isn't here today. So our response today links back to our response from last year, where we have asked for certain issues that keep reoccurring to be addressed in more detail. And some areas they have done that, and some areas they haven't. I thought what I'd do is I'd just pull out some of the, I haven't done a pretty slide like Chris, which some people will laugh at because I'm always banging on about making your information interesting. So unfortunately, you'll just have to listen to me waffle. So some of the themes that are coming out. So organisational culture and leadership. Now, the Health and Care Trust had a rating of requires improvement for well-led services. And there have been ongoing issues identified. So this year's quality account from the Health and Care Trust describes improvement in staff survey results. So they've been trying to do cultural change for quite a while. And part of that is to keep surveying staff on how they feel and what the problems are. They've now got a freedom to speak up initiative where you can go and talk in confidence about things that you think are going wrong. And there's ongoing leadership development as well. So these things are all ongoing. However, organisational culture and compassionate leadership are still not identified as explicit quality improvement priorities for the coming year. And as it is the foundation for everything, we would like to see them make that more of a priority. So a couple of other things I just wanted to pull out because they are things that we are constantly working on. So access to children's services and CAMS. So it outlines a lot of parents. So we know that a lot of parents contact us, and we welcome the inclusion of improving services for children, young people and families as a quality account priority for the coming year. And the report describes transformational programmes and intended service developments, but it gives limited information regarding current waiting times, expected improvements in access, delivery timescales, patient outcome measures, and expected impact on children and their families. So we would like to see more recording of that sort of information in their quality account. And linked to that, I suppose, is access to community mental health services. So this is another area that we as an organisation hear a lot about from patients. Our response welcomes the Trust's continued focus on assertive and proactive community mental health work. However, patients are telling us that there are still long wait times, difficulty understanding pathways and thresholds, inconsistent communication whilst waiting, limited continuity of care, and difficulty accessing support during periods of deterioration in their mental health. So we remain concerned that there are insufficient measurable commitments relating to waiting times. So we'd like to see more measurement of waiting times, more measurement of the communication standards, particularly during those long waiting times, and patient experience whilst waiting for care. So that's some of the feedback that we have, and I'll just cover one more area. I mean, you've had the response, so you can have a look at it in detail for yourself. But communication whilst waiting for services comes up time and time again, not just with mental health, but with lots of other services. So patients' carers frequently describe limited updates whilst waiting, uncertainty regarding timescales, difficulty contacting services, lack of interim support, and feeling forgotten. These are themes that we hear time and time again. So waiting times are referenced in the report. However, we would like to see the experience of waiting have a greater focus in the report, and a clearer way of measuring that, and being able to understand what patients are feeling at that point so that they can improve their communications within that wait time. So, yeah, just going on to the conclusion that there are some really good things in this quality account, but there are a lot of things missing that we have previously asked for. And so I would ask the board to sign this off as a response that I can send back to the Health and Care Trust. Thank you.
Any questions and comments before we sign this off? No. So are we all happy to send this our response? Yeah. Thank you. Next item 7, patient carer needs assessment report. Debbie.
Right. You'll have seen with the papers, we had a response from the council on the 23rd of April. We wouldn't normally respond to any responses they make, but we've made the decision on this occasion that we are going to respond to it. Obviously, I'm not going to read the letter out. You can read that in your own time, but the council has obviously welcomed the report and thanked parent carers for the feedback. They did note, however, that the findings were based on 27 completed responses, whilst recognising that the wider parent carer population is a lot larger than that. In response, they've set out plans for a pilot that they're running with a voluntary sector partner. So that is Carers and Communities, previously WAC, which they see as a practical test and learn approach to improving awareness, access, consistency and support. They've also acknowledged the need for better data and reporting, which they said that they'll be strengthening throughout that pilot. From a Healthwatch perspective, just to add some context to the point about the numbers, we were very transparent about the fact that there was only 27 responses, and we can only report on those that actually completed the survey and completed it in full. Whilst we were scoping this work, we did request data, which we do prior to every project that we run. We did request data on how many parent carer needs assessments are requested and completed locally to help understand the wider picture. That detailed data wasn't made available to us at that time, and further requests weren't fulfilled. So at the moment, there isn't a clear baseline to say whether that number is small in the context of overall demand. What we can say is that the feedback we received was consistent and reflects wider engagement about awareness, access, and how the process is experienced in practice. So for us, the focus is less about the number, but more about what those parents are telling us about how the system is working or not working. So we will be responding, and obviously we'll make that letter public, and we're also going to be asking for a bit more detail about the pilot, how it's going to work in practice, what's data they will be publishing at various points throughout the pilot. So that's just to update you on that, if anybody's got any questions.
Any questions or comments? No. Good, thank you. We will move on to the next item. We've had a expression of interest in membership of Healthwatch Worcestershire from Mel Smith of the Carers and Communities, and it's we have to decide at this meeting whether we accept that interest in membership. Are we all happy to accept? Yeah, I'm seeing lots of nods. So yeah, we accept as a board. Item 9, public participation. Is there any public participation? Any wish to speak? No. Any other business items? Debbie, you've got an AOB that you'd like
I
to.
have, yes. We just thought it would be appropriate to make a comment around the Send Reform white paper. Obviously, the consultation ended Monday, and we made a deliberate decision not to submit a corporate response because we don't have evidence that specifically reflected the consultation proposals themselves. Whilst parents, obviously I talk to parents all the time, and they were clearly raising concerns about the reforms. But the reason for them contacting us was specifically around their individual send problem. And that isn't the same as having a mandate to respond on their behalf with regard to detailed national reforms. So we made the decision not to do it. I obviously encouraged any staff themselves to respond, which I responded as a parent myself, and I am aware of another member of staff that did the same. We do signpost any parents that did actually contact us during the consultation period who raised concerns around the reforms. We did actually signpost them to national groups that were providing an awful lot of guidance to individuals to enable them to respond in their own individual capacity. There was lots of videos and templates from national organisations to support parents. At a recent Send and AP committee meeting, it was agreed that there would be key areas where the partnership, so that's within health and education locally, would want to capture collective feedback. So we've made the decision that we will be formally writing to the partnership, the PCF and Voices United, to request that feedback, how they fed back to the consultation, and to confirm that that will be published in the interest of transparency for parent carers. So again, we'll keep you updated on that, but our focus will remain on using local evidence to challenge all the meetings that I attend. That's it.
Thank you, Debbie, for that update. Are there any questions coming off that? Yeah. Good, thank you. Is there any other business from anybody? No. So yeah, that comes to the end of our meeting. Thank you for all attending this morning and giving you your time. The date of next Healthwatch Public Board meeting is the 16th of July, and it will be at 10 a.m. online. So we look forward to seeing you all then. Thank you.